In this lesson, we're going to take a look at how to identify peritoneal free fluid using our ultrasound. Identifying free fluid in the abdomen has been associated with worse outcomes for patients that are experiencing trauma or other life-threatening conditions such as ectopic pregnancies or aortic aneurysm rupture or dissection, or even just for patients that maybe don't have an acute injury, but that have severe kidney or liver disease that's causing fluid to back up and leak into the peritoneum. And so for a long time, the original anatomists and sort of masters and grandfathers and grandmothers of medicine who helped identify the anatomy and label it for us and help us to understand where things were in the human body have discovered this concept of pericolic gutters, which are spaces that are gravity dependent where fluid tends to first accumulate. And then since then, studies of surgical technique, and then now with our physical exam and radiologic exams, including things like ultrasound, we've been able to identify what fluid in the abdomen looks like and help use its presence to guide whether or not a patient needs to go urgently for surgery or to get additional studies prior to decompensating. So accordingly, this is an assessment that is often utilized in trauma as the FAST exam, and this is often the first introduction that medical students or residents get to using point-of-care ultrasound to make management decisions. And while it is still important in trauma, as a family physician, I often am not seeing trauma patients immediately, although every now and then when I'm working in the ER or moonlighting at a community hospital ER, I do utilize this for that purpose. But sometimes I use it just to assess, patients that have an acute change on the floor in the hospital, or patients who are in clinic who have severe kidney or liver disease, or who have abnormal vital signs, as a quick assessment to see if this patient is someone that I can safely manage, or if I need to involve my surgical colleagues or my radiologic colleagues to get additional studies done to figure out what might be going on for a patient who's decompensating. As with other abdominal exams, our probe of choice is going to be the curvilinear probe. However, the phase array probe is often utilized for things like the eFAST exam, which would be looking for free fluid in the abdomen. So either one of these is well suited to identifying peritoneal free fluid. Positioning for our patient is often going to be supine. However, there have been some studies that have shown that if you can put a patient in Trendelenburg, just a 5-degree tilt may increase the diagnostic threshold, reduce the diagnostic threshold by 200 cc's of fluid. And so if you can catch someone who's got 300 cc's of fluid in their abdomen as opposed to requiring 500, obviously that would be a big benefit, and we could get those patients seen faster and treated faster and hopefully reduce the morbidity outcomes. The diagnostic threshold for looking for free fluid in the abdomen varies according to the amount of fluid that's present. So if there's 100 milliliters of fluid, and we'll presume that that's blood in this case, as seen by our little red water bottle here, that's floating around inside the abdomen, the sensitivity of a point-of-care ultrasound is likely to be somewhere around 85%. If that amount of fluid increases to 350 milliliters, that sensitivity increases to 93%. And then by the time that the patient has lost 750 milliliters, the sensitivity is greater than 99% for detecting that fluid. I want to have one slide that just focuses specifically on the history of the eFAST exam. So this, like I mentioned, was one of the first applications of point-of-care ultrasound. And the advent of this exam really started in Europe in the early 1970s, and then made its way across the pond over to the USA in the early 1990s when point-of-care ultrasound first started to take root here in the emergency departments and in the ICUs. The eFAST is now considered to be an adjunct exam to the ATLS primary survey for trauma patients, and a standardized eFAST exam consists of 5 windows, one in the right upper quadrant looking at Morison's pouch, one in the left upper quadrant looking at the splenorenal recess, one looking at the subxiphoid cardiac view for a large pericardial effusion, and specifically cardiac tamponade, a pelvic view to look for pelvic free fluid, and then a pulmonary exam that evaluates for pneumothorax and for pleural effusions to help identify why a patient might be hemodynamically unstable following a trauma. Patient positioning, like I mentioned, should be supine or mild Trendelenburg. And in the setting of family doctors or sports medicine physicians who I often teach, it's important to think about the other things that may be present on the patient or around the patient that can affect the positioning of the exam, because proper patient positioning improves the sensitivity more than the volume of hemorrhage does. And so if you have a patient that comes in and they're still wearing pads or helmets, or they're laying on a couple wads of blankets or sheets or pillows, those things can disrupt the anatomy, and those paracolic gutters may not be the most dependent portion of that patient on the table. And so positioning is super, super important for an eFAST exam or any exam where you're looking at intra-abdominal or intrapelvic free fluid. Let's start off by looking at the right upper quadrant view of our FAST exam. This is the standard view that I want you to memorize and aim to get every time that you're examining the right upper quadrant doing an eFAST exam. So we can see that we have, let me get my pointer, the spongy gray liver with our kind of mid-level echogenicity. We have a hypoechoic kidney immediately adjacent to it inferiorly. Superiorly, we have the diaphragm, a nice hyperechoic line, and then the pleural space here above it. And a couple of points that need to be addressed here is that you have to visualize the inferior tip of the liver, which is off screen on this view, as well as the inferior pole of the right kidney to have an adequate exam. Because sometimes you'll have small amounts of fluid that collect around either of those places that aren't visualized in this more standard view. And so it's super important that you visualize all of those structures when assessing for the fluid in the right upper quadrant. Let's take a look at some examples of positive screens. So here we have an example of the right upper quadrant. Here is our kidney, and we have our liver over here. And we can see that there's a collection of anechoic fluid surrounding this inferior tip of the liver, as well as in the hepatorenal recess or Morison's pouch right here in the the hepatorenal recess. And this is an example of a pretty large amount of fluid in this area. Over on the right, we also have a more subtle finding, but here it's just sort of isolated in this hepatorenal recess, but this sliver of anechoic fluid, and maybe a little bit here above the liver, that represents fluid, presumably blood, in a trauma patient, that would indicate that there's probably an injury that needs to be evaluated surgically. Now, one kind of thing that can trip you up is that, see here that there's this anechoic appearing section, but that it changes with respiration. This is not fluid. This is attenuation of the ultrasound beam. So remember that as ultrasound waves come in at deeper depths, they will have a weaker signal returning back to the probe, especially when they're going through dense structures such as the liver. And so this is ultrasound beam attenuation. It is not fluid and should not be confused as such. So it may mean that you need to slide your probe or adjust your gain to visualize this area better. So a positive right upper quadrant study can include suprahepatic fluid, fluid that's lying above the liver, below the diaphragm, or it could be fluid in Morison's pouch, which we see here, or it could be fluid at the caudal tip of the liver, which is here. And this is the most sensitive finding, is right here at the inferior tip of the liver. And so that's why it's so important that you visualize this section, and including to the inferior pole of the kidney, before calling a right upper quadrant view negative. But wait, there's more. So in addition to the right upper quadrant of the abdomen being evaluated in this study, we can also see that this evaluates the right hemithorax for a pleural effusion. And the way that that happens is because generally in a healthy patient, such as in this image, there is a very poor penetration of the ultrasound waves into the hemidiaphragm because this is a space that's filled with lung tissue and air. And so what we see is an artifact called mirror artifact, which we'll go over on the next slide. But basically what happens is that you get a reflection of the liver above the diaphragm. And in fact, if there's like a hemangioma or a large vessel here in this section of the liver, you might actually even see that architecture displayed above the diaphragm. The second thing that you can see is that you see the vertebral bodies here moving up, and then they seem to stop at the level of the diaphragm. And that's because the fluid that there's no fluid up here inside the thoracic cage to transmit waves, so we're not going to be able to reach the vertebral bodies and get reflections. However, if there's a pleural effusion, in addition to anechoic fluid that collects up here, you will be able to see those vertebral bodies in the thorax, and that's called the thoracic spine sign. I'll show you an example of that as well. Let's go over mirror artifact first. Mirror artifact can be a little bit confusing, but I promise it will click eventually. So basically what happens is that sound waves will hit a reflective shiny surface, and some will bounce up to the transducer. However, some will get bounced sideways and we'll never see them again, and we don't need to worry about them. But some of those sideways reflected waves will bounce off of things inside the liver and be reflected back off of that curved structure of the diaphragm up to the ultrasound probe. Now the machine doesn't know that it's had that little side trip to the side, and so instead it thinks that these waves are reflecting off of a deeper structure. And so the machine will generate a ghostly image on the opposite side of that reflective structure that represents a mirror artifact. We went over this in our physics lecture in the first module, and so if you need some more review for this, because it is a little bit confusing, go back and review that lesson. So once again, this is what a normal right upper quadrant ultrasound would look like. With a negative FAST exam, we see the mirror artifact generating a liver-looking appearance above the diaphragm, and we do not see the thoracic spine sign. We see that those vertebral bodies seem to stop at the diaphragm. Versus here, we have a positive right upper quadrant FAST with a positive pleural effusion. So here is our abdominal fluid. So this is a patient that has severe ascites and hepatohydrothorax. And then in this patient, we can see that there's a collection of anechoic fluid here that does not generate that mirror artifact of the liver. And then furthermore, we see the thoracic spine continuing above the diaphragm, and this is called the thoracic spine sign. So these are both indications that there is a positive pleural effusion in the right hemithorax. Next, let's move on to our left upper quadrant exam. The left upper quadrant exam can be a little bit more challenging just because the kidney and spleen are much, much more superior and posterior to the liver. And so this really takes you kind of reaching all the way around your patient, putting your knuckles on the bed, going super posterior to try to visualize these structures. The spleen will have an echogenicity similar to the liver with a hyperechoic diaphragm and hypoechoic renal calyces visualized here. So you can see it sort of mirrors the right upper quadrant, but that there is a slightly smaller space that you're visualizing. And once again, this is a negative exam because we're not seeing any anechoic fluid above the spleen, between the spleen and the liver, or at the inferior pole of the liver if it was visualized. Let's see what a positive left upper quadrant view looks like. So here's a positive left upper quadrant view. We can see our spleen here, and we see anechoic fluid with some debris here in the near field above the spleen, and then even starting to come down into the splenorenal interface. And so this is what a positive left upper quadrant view looks like. And once again, you can see that that anechoic fluid disrupts the normal pattern of the spleen being adjacent to the diaphragm, adjacent to the kidney without any anechoic findings. Here's the blood. So some key takeaways for examining the abdomen are that the most sensitive portion of the right upper quadrant is going to be at the caudal liver tip, and that's actually going to be the most sensitive area for our entire FAST exam for abdominal free fluid. And then the most sensitive area of the left upper quadrant is going to be subdiaphragmatic or perisplenic fluid, not in that splenorenal recess. Mirror artifact is usually normal, and the spine sign is not normal. Now let's jump down to the pelvis and see what those views look like on a FAST exam. So spoiler alert, male and female patients will differ in their pelvic anatomy. I know that is a surprise and it wasn't something they taught you in medical school, but just take my word for it. There is a difference in those, those pelvic organs. So depending on the biologic sex of your patient, you may need to be able to recognize, what does a prostate look like? What does a uterus look like? Because fluid will accumulate in slightly different places depending on the pelvic anatomy. So I've got this anatomic representation here of a male on top with a bladder and prostate and the seminal vesicles, but there's no solid organ here in between the bladder and the rectum. And so fluid in males will tend to collect at the rectovesical or rectovesicular pouch here between those two structures. Whereas with females, because of their uterus, it will usually collect in the rectouterine pouch or the pouch of Douglas behind the uterus. And so you need to visualize the uterus and be able to see that. The other thing is because there's a lot of kind of small nooks and crannies in the pelvis between all of these different organs, it's really important that you get both longitudinal and transverse views when looking at your patients. So you'll start by holding your probe centered over the pubic symphysis and tilting it caudally to visualize the pelvic organs, and then you'll fan your probe back and forth in the longitudinal and in the transverse view to be able to fully visualize these spaces. Let's show you some examples of positive findings. So here we have examples of positive pelvic free fluid. Here on the left is a patient with a uterus, and we have the urinary bladder here as an anechoic structure. We see the uterus, and in fact there's an IUD on the inside of this uterus here. But what is positive is that we see a collection of anechoic fluid right here, and even right here between the anterior portion of the uterus, and that is free fluid that is in the pouch of Douglas right here. So that is a positive pelvic FAST. Over here we have a male patient, and here we can see the urinary bladder, and then just immediately posterior to the urinary bladder, superior over the dome of the bladder, we have a collection of anechoic fluid, once again representing a positive pelvic FAST. So to review what we covered in this lesson, we talked about the search for fluid and why it's important for us to be able to identify fluid in the abdomen of our patients. Namely that this could escalate their care, send them to the operating room faster, help them get specialists on board that can care for their advanced kidney or liver disease, diagnose an ectopic pregnancy, and otherwise help us manage critically ill patients. We talked about the indications. We also discovered some pearls about the exam technique. We talked about how the diagnostic threshold for a positive exam naturally, as we would expect it to do, changes based on the amount of fluid present, with higher amounts of fluid having a higher sensitivity. We also talked about the different imaging windows and went through each of them, looking at the organs and what looks like normal, and also reviewed some positive findings and examples of positive findings. I would encourage you, if you need to go back and review the ectopic pregnancy lecture that I placed on the channel earlier, because that will give you a little bit more detailed view of those pelvic structures, which are usually the hardest windows to fully visualize in the FAST exam. So if you get a chance, go back and review those. But if not, we will see you in the next lesson.